The broadcast is now starting. All attendees are in listen-only mode.
Well, good evening, all of you hormone enthusiasts. Welcome to Question Lab. Tonight we are going to be focusing on the endocrine system. I'm Jeff Downing. I am the Senior Product Director at USMLE-Rx, and really excited to jump into another session here. I think this is either 176 or 177 Question Lab, and tonight I am once again joined by Dr. Abraham Titus. Abraham, would you mind introducing yourself to the crowd?
Cool. Thank you, Jeff. So as you mentioned, my name is Abraham Titus. I'm a hematology and oncology fellow down south here at University of South Alabama. I'm excited to go over some endocrinology questions and talk about some high yield topics regarding step 1 endocrinology. Hope you guys are, brought your minds to get grown and learn more about the endocrinology topic today.
That is what it is all about. Showing and growing, showing what you know. And tonight we're going to be exploring the world of endocrinology, and it's obviously this is out of all of the different systems, this is the wild one. It's got all these tiny molecules traveling through your bloodstream. It's carrying messages that literally change how every cell in your body behaves. So whether you're a first year, just kind of getting started and trying to figure out what the various terms mean, or you're in frantic board prep mode, just trying to remember the difference between type 1 and type 2 diabetes. Tonight the session is going to hopefully help clarify some of these concepts. So a little bit about Abraham and me. So what we want to do is we want to learn a little bit about you. So I'm going to launch this first poll, and as you know, here in the webinar we use the quick poll functionality so that you can answer the questions as we go through them, and we highly encourage you to answer every question to the best of your ability, but don't sit it out. This should be an active learning session for you, and even if these are concepts that you're rusty on, or that you're or maybe you feel like, I think I know this. This is always a great opportunity to really test yourself. Always a bit of a diagnostic, and perhaps there will be some things that you learn tonight about your own gaps, or things where you might want to spend more time and attention. Really wait until about 3/4 of you have voted, and I think we've hit that threshold, so I'm going to close the poll and share the results. So tonight we've got strong showing of IMGs and FMGs. Also have quite a few M2s in the crowd and some M3s and a sprinkling of M4s. Don't have any M1s, so it's too early, I guess, for some of the newbies. But we are really happy that all of you decided to join us tonight. So I'm going to hide the results. So, here at USMLE-Rx and USMLE-Rx, we've been bringing you Question Lab for 5 years now, a little over 5 years. And this is a free workshop, and the main thing that we want to do is help you prepare. And we talk about content, but we also want to talk about approach. There is a method to this madness. So as we go through it, we're going to basically model how we approach questions and how we teach to approach questions. Okay, so maybe you already have your own technique, or maybe you have one that you're developing. That's great. For our purposes, we just want to make sure that on test day you already have a system for slicing and dicing questions. Okay, and if you are at the stage where you're just starting to to put it into practice, perhaps some of our tips will help sharpen your your own techniques. Okay, so again, we're gonna walk you through that as we go through each item. Okay, so tonight we've got 4 questions for you. We will have a raffle at the end of the episode or the workshop, and we'll have a special offer for those that are looking to add USMLE-Rx to their arsenal. Okay, so that's what we've got lined up. If you've got questions, head on over to the question box, and we'll do our best to answer them. Again, we have a lot of people that join us, and sometimes we get a lot of questions, so please be patient. But we definitely encourage your questions. We want to hear about your thought process, so let's all learn together, right? Hormones may work through feedback loops, but knowledge flows in all directions. So let's go ahead and get started. Here is question number 1. Now, for you newbies, when I reveal the question, you're going to see that something's missing, right? And those are the answer choices. So our first step is asking you to cover up the answer choices. So, maybe that feels weird or wrong, but we do it because some of these answer choices that you'll see on step 1 are definitely designed to mess with your head. They're going to throw in terms you've never heard of or things that you half remember, and you might wind up second guessing everything. So we say first, cover up those answer choices, and then we want you to read the lead-in first. So in this case, the lead-in is which of the following best explains the abnormal serum studies in this patient. So, that's the question you're trying to answer. On the USMLE, you'll sometimes see long Byzantine vignettes, and some of them are pretty detailed. And if you don't know what the the story or the case is about, you can get lost in all the random details. Someone's pet cat or or whatever. So the main thing is we ask you to read that lead in first, because the lead in provides a way to frame it, right? So now you know what it is you're actually looking for. And with that in mind, then you can go back and read the vignette. And the vignette obviously is going to have the information that will help you hopefully get to that answer, right? So with that, let us read the vignette. A 60-year-old woman with a history of type 2 diabetes mellitus, chronic kidney disease, and hypertension comes to the clinic for follow-up care. Examination shows ankle edema, and here's what the serum study shows. So you can see the creatinine level at 4.7, glucose 320, calcium 6.5, phosphate 6.0, and parathyroid hormone 672. So again, which of the following best explains the abnormal serum studies in this patient? Now, I'm going to pass it over to Abraham to walk us through it, but you can always kind of think about it even before you see answer choices. You can begin to hypothesize what that answer might be. So with that, I'm going to pass it to Abraham.
All right. So we have a kind of a classic question. Not just a simple question of, what's the diagnosis? They can ask them what explains the abnormal serum studies in this patient. So let's go through, let's highlight some keywords here. Let's try to pick out what I need to focus on. So again, like Jeff said, the most important thing is reading the lead in, right? Because they can throw a curveball right at the end. You can really know what's going on, but if you miss what the question is really asking for, you can always miss the answer. So abnormal serum studies in this patient. Okay, straightforward. We got a 60-year-old woman, past medical is always important, or diabetes, CKD, hypertension. And comes in with some ankle edema. Now labs, I always want to make sure I take a good look at especially the high yield labs, and there's no reason why they're giving these particular labs. So creatinine is 4.9, so that's pretty high. No, around 1 is what we look for, is normal. Glucose 320 is pretty high. Calcium 6.5 is considered low, and phosphate 6 is high, and PTH 672 is pretty high. So we have this particular pattern of labs we need to look at as well. In addition, you have the past medical history, and really they're asking you, why are these lab work showing up the way they are? What is the underlying explanation for this? So take a second, really process that, and just like Jeff said, start thinking about why. Now, when we pull up the options, you should already kind of see your thought process already there. And that's kind of makes it easy. Don't get caught up in the weeds of the distractors. I'm going to read through the options. I like to start with E and make my way up just to make sure we kind of I don't get caught with an obvious distractor. Option E, vitamin D intoxication. Option choice D, parathyroid insufficiency. Option choice C, parathyroid adenoma. Option choice B, malignancy. Option choice A, chronic kidney disease. Now, take a second, read through the question one more time, try to understand why the lab values are the way they are, and what is the best explanation for why the situation is happening.
Okay, with that, I'm going to go ahead and launch the poll so that you can tell us which of the following best explains the abnormal serum studies in this patient. Again, you never want to leave a question unanswered on test day. You won't be penalized for it. And of course, you could get lucky. But the main thing is, you want to just keep kind of narrowing it down, especially if you don't know it right off the bat. Just narrow it down to the the options that you think are most plausible, and just you want to work through it. You don't want to spin out, right? On test day you are also working against the clock, but just think about the ways in which you can really get your raise your chances of getting each of these questions right. Okay, I am going to poll. We've got almost some of you voted, so I'm going to close the poll and let's share the results. And whew, that is an overwhelming number here. Almost 80% of you went with answer choice A, chronic kidney disease. And some of you went with answer choice C, parathyroid adenoma, and some with parathyroid insufficiency. So, gosh, in all of my days of helping run Question Lab, I can't remember too many questions that have gotten some overwhelming consensus. So let's see how we did. So I'm going to hide the results and reveal the answer. And the answer is indeed answer choice A, chronic kidney disease. That was apparently an easy one for you guys. So great job. But if you didn't get it right, or maybe you were guessing, or you weren't quite sure why you got it right, that's okay. That is why we are here. So I'm going to let Abraham walk us through it.
Great job, guys. And yes, this first one is an easy layup. We usually start with the easy ones and kind of make our way into the more difficult questions. But congrats to you guys. A lot of you guys were able to pick this out right away, that this is the answer. I think really thinking about the diagnosis prior to looking at the options really helps in the situation. When I look at the options, you start seeing things like parathyroid adenoma and issues with the parathyroid gland, then you can get distracted easily and lose track of the underlying problem. So the concept of this question is still very high yield. Although this question is a pretty easy one, you want to make sure you understand the details of it and why the other options are incorrect, and what I would expect the labs to look like if the patient had option choice B, C, D, or E. Okay, so first things first, you want to look at the patient. You say, okay, this patient has chronic kidney disease, secondary to diabetes, and hypertension. Good. Now, creatinine elevation is typical, we expect in CKD, and the glucose elevation is likely in the diabetes situation. Now, why is the calcium low and the phosphate high? Now, this can occur secondary to the underlying CKD, and that can then trigger what's called a secondary hyperparathyroidism. So that explains why the PTH is elevated. And we need to know what the normal function of PTH is in order to really understand why that's happened. So the PTH, the normal function, is to increase my calcium and get rid of my phosphate. So it's doing the opposite of what's happening here. So that's why it's a secondary, right? So the PTH isn't what's driving the underlying labs. The fact that the calcium is low and the phosphate's high points towards the PTH elevation is secondary to the high phosphate, low calcium situation. So CKD is the correct answer because of that. Option choice B, for example, is malignancy. So malignancy by itself can cause something called hypercalcemia of malignancy. So if I see high calcium, nothing else really going on that can explain that, you can consider malignancy as the cause. Particular cancers like squamous cell of the lung can cause thyroid-related peptide release, which is the paraneoplastic syndrome. That can also cause hypercalcemia. It's a little bit higher level question, but definitely very high yield. Option choice C, parathyroid adenoma. I got a lot of you guys, when you see the high PTH, you're tempted to. Parathyroid adenoma would cause primary hyperparathyroidism. So in those situations, yes, your PTH is going to be elevated, but your calcium will be up and your phosphate will be down. That's the opposite in the situation. Parathyroid insufficiency. Well, sure, that would explain the low calcium, high phosphate, but your PTH levels would be down, which wouldn't fit the case. And then vitamin D intoxication, again, you would expect hypercalcemia in that situation, not hypocalcemia. And the whole picture just points towards CKD being the underlying problem. But great job, guys, on this one. Again, like Jeff said, this is a landslide, but even if you didn't get it right, don't feel bad. This is a learning opportunity.
That is the truth. So again, great job, everybody. We're off to a good start. So let us go to question 2. And again, we've got the answer choices covered up. And in this case, we start with the lead in, which is which of the following serum abnormalities is most likely in this patient? Okay, so again, thinking about that, thinking about, well, what is going on here? And, again, you can kind of use that question as a bit of a map through the vignette. Okay, so let's read the vignette. A 13-year-old girl is brought to the emergency department by her parents because of abdominal pain and vomiting. She is very lethargic and unable to answer questions. Temperature is 38.5. Respirations are 28 per minute. Physical examination is significant for deep, rapid breathing, dry mucous membranes, and poor skin turgor. Lab studies show a blood glucose level of 280. So once again, which of the following serum abnormalities is most likely in this patient? If you can think of, maybe you don't necessarily have them coming straight to mind, but, think about what answer you might expect when we reveal those answer choices as I turn it over to Abraham.
All right, so this question's a little bit different than the last one, a little higher level, but it kind of flips it on its head, right? As opposed to asking you what's causing the serum abnormalities, this one's saying, what serum abnormalities do I expect in this patient? There's a little flip. So let's go through, let's highlight some keywords here. Let's talk about what the most important things in this question is. So again, start with the lead in. Following serum abnormalities is most likely in this patient, right? So you have to see what the patient has, diagnose them, and then see, if I were to get labs on this patient, what would it look like? All right, so we have a 13-year-old girl. So this one's more of a pediatric case and came in with abdominal pain and vomiting. Okay, pretty non-specific, could be anything really at this time. Lethargic, sure, and has a fever, 101.3, that's a real fever. And, has deep, rapid respirations. Okay, so that's fast, breathing 28 times a minute. Dry mucous membranes and poor skin turgor. Okay, what do they mean by that? And the glucose level is 280. Okay, so using all this information, the clues that they gave you in that, you should start thinking about a diagnosis just based on this, right? So this isn't that much information, but it's enough to start formulating a diagnosis in this situation. And always want to think common things are common and just really try to understand what this patient has this time. Then, using all that information, think about if I were to get labs on this patient, what serum abnormalities I'm most likely to see, in addition to what they already tell you. So start thinking about the different labs, think about your CBC, your CMP, all these different things and what you expect to see in all of your labs. As we pull up the options here, you should be able to see one of the ones you're thinking about. So let's look at the options here. So we have, again, 5 options. Talk about anything from your electrolytes to your bicarb to your carbon dioxide to your any kind of anion. So let's go through. I'm going to read through the options here, and we're going to pull up the poll right after that. Okay. Option choice E, normal anion gap metabolic acidosis. Option choice D, increased serum bicarbonate. Option choice C, increased blood partial pressure of carbon dioxide. Option choice B, hyperkalemia. Option choice A, hypercalcemia. Now, these are all different electrolytes versus bicarbonate and carbon dioxide with the normal metabolic acidosis. And these are different lab values you can expect in a patient. But really, the way to get to this answer is diagnosing this patient first. We use the history, use the clinical clues they're giving you, use the physical exam to really come up with a diagnosis, and that will make this question a million times easier than trying to get to the answer with that. So take your time, go over the vignette one more time if you need to, and give us your best shot.
Okay, the poll has been launched, and I'm going to have a bit of a serum theme tonight, so hopefully everyone here will benefit from going a little bit deeper on this topic. I know for some of you, you might be starting your clinical rotations this week or last week. Some of you may be getting ready for the start of the new year, so let us know in the question box what you're excited about, what you're doing. Love to see you guys as you progress on your journey. All these future doctors here in the house. Got a good crowd here too for Tuesday night in early July. So let's see, we've got almost 3/4 of you voted, so I'll give you just a few more seconds before I close the poll. Okay, let's close it and share the results. So let us see. So top vote getters, hyperkalemia. A little over 1/3 of you went with that one. Normal anion gap metabolic acidosis came in second, and increased serum bicarbonate came in third. This, both of them pulling in about 1/4 of the vote. So, not exactly a three-way split, but three big vote getters. So let's hide the results and reveal the answer. And the answer is hyperkalemia. So well done, everybody. 38% of you went with that one. But if you didn't, that's okay. We are here to make sure that you get it right on test day, right? So let's walk through it with Abraham.
All right, great job, guys. Again, a little bit more difficult question, and as you can see with the split, you can kind of see that, but you still were able to get that right, majority of you guys. And even if you didn't, we're going to talk about it. We're going to learn this topic, and next time you get this type of question, hopefully you'll be able to get it right. So let's start with diagnosing the patient. That's the first step, right? Like I mentioned. So we have this young female, has high glucose, and then has like these dehydration symptoms, right? So mucous membranes, poor skin turgor, and then has a fever and rapid breathing, right? This patient is in DKA, diabetic ketoacidosis, right? Kind of fits the picture. 280 is not a crazy high glucose, but it's high enough in the setting of this clinical picture in a young female. We should really think about DKA. DKA, why do they get vomiting? Well, it makes sense. Well, because if their body is so acidotic, they have to find a way to get rid of some of that acid. So stomach acid, they vomit out. That's our body's compensatory mechanism. Why are they breathing so fast? Well, they're trying to do respiratory alkalosis to compensate for their metabolic acidosis, right? So DKA is an important concept to understand. Lots of questions on it. It's going to be one of the most tested things in endocrinology, and they ask it in many, many different ways. But you should always have a young female or young male patient with high glucose and then presenting with abdominal pain, lethargy, and dry mucous membranes, things like that. You should start thinking about DKA right away. Now, once I know that it's DKA, which is caused, in type 1 diabetes due to, increased ketone formation, there's usually some kind of trigger like infection or starvation or something like that that kind of pushes it one way or the other. Now, what do I know about type 1 diabetics? They are deficient in insulin, okay? And that really is the underlying problem. When I don't have insulin, right, the role of insulin is very important in the human body. Insulin helps regulate this potassium. It helps put potassium into our cells for us to use. So when patients become deficient in insulin, that potassium that should be intracellular, right? If I take all the potassium in the human body, about 90% of it should be intracellular. Only 10% is floating around in the blood. So when I check the blood to check potassium levels, I'm only looking at the potassium that's outside of the cell. So in this situation, when I have hyperkalemia, truly the patient might actually be potassium deficient as a whole. body, like the inside of their body, will have low potassium, but the serum or the blood test that we do will show us high potassium because we don't have that insulin pushing that potassium intracellularly. That's a very high yield concept to understand. So hyperkalemia is kind of a flag mark indicator of insulin deficiency. Similarly, this goes into a different nephrology topic where how do you treat hyperkalemia? You give insulin and glucose. So you essentially shift that potassium that's floating around in the blood into the cells. Now let's look at why the other options would not be the right answer. Hypercalcemia doesn't really fit the picture in this situation. You're going to have more of a constipation. See a picture with like some lethargy and that stones, groans, psychiatric overtones, this classic mnemonic that we learned from first aid. That's kind of what they'll focus on. Option choice C. A lot of you guys, some of you guys picked that one. That one's increased amount of carbon dioxide. Well, the patient is breathing really fast, right? So you would expect low amounts of carbon dioxide. They have a respiratory alkalosis, as opposed to if somebody took opiates or someone has COPD where they're retaining a lot of carbon dioxide. That's when C would be a good answer. Option choice D, increase serum bicarbonate. Again, when I increase my serum bicarbonate, I'm thinking metabolic alkalosis. And in this situation, the patient has in DKA. What does the A stand for? Acidosis. So they have low serum bicarbonate. So they're in metabolic acidosis. And option choice E is the big distractor that caught a lot of people. It's not a normal anion metabolic acidosis. It is an anion, elevated anion gap metabolic acidosis. Remember that there's a mnemonic that we learned. It's mud piles, or there's many different mnemonics that come out there. But I learned it, and those ones, particularly DKA, is an important one to remember. Is an anion gap metabolic acidosis. So in this situation, the way you diagnose the patient with DKA is most important. And somebody asked about the abdominal pain. Really, no one really understands the physiology behind the abdominal pain in DKA. It's just something that occurs, and there has not been a scientific study saying why do you have this. But in general, the vomiting, the lethargy, dry mucous membranes is important to understand in DKA. But good job, guys, and hopefully next time you'll be able to understand DKA a little bit better if you got this wrong.
Yep, very great job, guys. You guys are you're off to a really nice start. We're at halftime, time for the halftime stretch, and just a quick reminder that while your hypothalamic pituitary axis might be working overtime trying to process all this endocrine info, we here at USMLE-Rx and ScholarRx really want to help you here, whether you're preparing for the boards or just looking to succeed in med school. If you are unfamiliar with Rx, we do have a free trial, and you get 5 days of access to everything, including our Rx bricks. So you might be thinking, great, another steady resource to add to my already overwhelming pile. But what's the nice thing about the bricks is that well, how your endocrine system uses feedback loops to maintain homeostasis. Well, the bricks kind of do that for your learning. They break down complex topics into manageable pieces, and then with active learning questions and reviews and integrated connections to everything from the other elements within the Rx ecosystem, you can come away with a really deep understanding of the things that you actually need to know in order to succeed, whether it's on the boards or on the wards. So in any case, we do have a special offer for you. We'll talk about that here at the end of the night, but definitely want you to be thinking about Rx, as you're getting ready for this new academic year. With that, let us jump to question number 3. And again, we've got all of the answer choices covered up. And you can just look at this one. It's like, wow, I got a very short vignette, and when you see these types of questions, you're really going to have to, it's like almost every bit of information may be useful. So let's read that lead in first. Which of the following is most directly responsible for this newborn's abnormal serum test results? So again, we're back back to the serum labs, right? So understanding what it is you're looking for, what's most directly responsible, let's go ahead and read the vignette. Physical examination of a female neonate reveals an enlarged clitoris with incomplete fusion of the labia. Serum studies show a sodium level of 131, potassium of 5.7, chloride of 100, and bicarbonate of 21. Okay, so again, you've got all of that data. Now, which of the following is most directly responsible for this newborn's abnormal serum test results? Think about, what might be causing this, what your hypothesis would be as I pass it on to Abraham.
All right, so we got a little bit different question here. We had neonate, we're dealing with a little younger population, and we're thinking about, again, serum results, but the question itself is, again, talking about a clinical picture. They do give us a lot of labs, but they're asking, what would be the most directly responsible? So let's go through, let's highlight some keywords here. When these short questions are there, typically a lot of important stuff is jammed into that question, right? So you want to make sure you read it, make sure you understand all the information they're giving you, and kind of mentally keep in mind, okay, this is high, this is low, this is important or not. So let's read it one more time. Most directly responsible for the abnormal serum lab test, okay? So we have female neonate, a large clitoris, we have an incomplete fusion of the labia, okay? So there's some, reproductive issues there that's going on. Sodium is 131, potassium is 5.7. So we got a slightly low sodium, high potassium, chloride's 100, sure, and bicarb is 21, right? Bicarb is a little bit low at 21. So what does that really mean? And what does this pattern mean? Okay, they're not giving you very much, but they're giving you key pieces of information that you have to plug together to really kind of fit into something that just makes sense. Maybe a syndrome, maybe a condition that explains everything in one go. We call it a unifying diagnosis, and a lot of the step is going to be really finding a unifying diagnosis that checks all the boxes. You can think of a few syndromes that can cause one of the issues. They can cause hyperkalemia, or they can cause low bicarb, but what is really going to explain all of this in one go? All right, let's pull up the options here and let's go through it one by one. With option choice E, increased testosterone. Option choice D, increased androstenedione. Option choice C, increased aldosterone. Option choice B, increased 11-deoxycorticosterone. Option choice A, decreased mineralocorticoids. So it's a mouthful for some of these, but these are all very important, and they're all really pointing towards different conditions you should be aware of. And we're going to go into each of them and really what they are really hinting at with each of them. So take your time, think about the serum, the test that they tell you, think about the physical exam, and think about, what condition could this be? And then in that condition, what am I going to see in the serums? So a little bit more difficult, a little more challenging. Sometimes I find that the shorter questions are actually a little harder than the longer questions, but it's about finding that, getting into the test writer's mind and really see, okay, what are they testing here, and running with it.
Okay. Well, you've got your marching orders here. Go ahead and let us know what you think is most directly responsible for this neonate's test results. Appreciate all of the nice notes in the question box. We do have a discount that we're gonna tell you about here at the end of the evening. We'll have a raffle. Someone's gonna walk away with a 3-month subscription to RX 360 Plus. And I did put a link to the question lab playlist in the chat. So, and honestly, I hear from students on a weekly basis who told us that that they spent a long time watching, old question lab episodes as they were preparing for the board. So, happy to see that these continue to have value. You could basically watch question lab for 7 days straight without watching a repeat. So, okay, with that, we've got, looks like almost 80% of you voted. So I'm going to close the poll and share the results. So interesting spread here. About 38% of you went with decreased mineral corticoids. Quarter of you went with answer choice B. Androstenedione, the answer choice D, came in with 18% of the vote. Increased aldosterone, 12%. So, and some of you went with increased testosterone. So, okay, well, let's see. The correct answer is, I'm going to hide the results and reveal the answer. And the answer is indeed answer choice A, decreased mineralocorticoids. So, great job, everybody. A little trickier question, especially when you've got all of these kind of high yield data points in the vignette. So nice work. Tripped up on it, or if you're not exactly sure why you chose answer choice A, that's okay. Abraham is going to lead us through this one.
All right. Well, great job, guys. Again, this is another tricky question, and especially with just the limited information they're giving you, really they expect you to draw a lot of information from those two sentences. Okay, so let's go through the question again. Let's really understand what they're trying to test here. Okay, so again, it's not about coming with a diagnosis, about what's most directly responsible for the patient's abnormal test results. So you have a female neonate, they're telling you it's female, with masculine features, right? So enlarged clitoris, incomplete fusion of the labia. So a lot of these things that you would expect when you have what's called virilization, right? So some virilization, so high, that can be explained with maybe some of the increased androgens. So that would be, like a lot of you guys pick D and E, both of those can be seen, the increased androgens, right? So those are both testosterone and androstenedione, both go up in all types of congenital adrenal hyperplasias and in aromatase deficiencies, but it wouldn't account for the electrolyte problems that are going on, right? So you need to look at the full picture, right? It's not asking about why do they have this physical finding, right? That's what's important to read the lead-in. You have normal serum tests. So it's really wants you to hone in and focus on the sodium, potassium, bicarb. Why are those off? So, the fact that you guys picked a D and E, those are technically correct. Those are going to be high in this situation, but it's not responsible for the serum abnormalities. And that's where the trick comes in. That's where the lead-in, really understanding that, comes in. Okay, so don't feel bad if you guys pick those. Now let's go work our way up to the other options, right? So let's look at these electrolytes and really understand it. So what is the function of aldosterone? Really, whenever we talk about pathology and abnormal stuff, you always want to take it back and be like, hey, do I know the normal? Do I know the physiology? Do I know what aldosterone does? And a lot of my students I talked about, hey, tell me what aldosterone does. So aldosterone should have an effect, right? So aldosterone is also known as mineralocorticoid. So option choice A and C are directly opposite of each other. That's another clue they're trying to tell you. And aldosterone and mineralocorticoid is the same thing. What they do is they bring in sodium into our body in exchange for potassium. So it gets rid of potassium, brings in sodium. That's the primary role of aldosterone. Okay, aldosterone brings in sodium, gets rid of potassium. So if someone has high aldosterone, we expect sodium to be a little bit higher and potassium to be lower. And the secondary function of aldosterone is to bring in bicarbonate and get rid of hydrogen ions. So you're going to expect somebody to have high bicarbonate, low hydrogen ions. So option choice C goes out the window right there. As soon as I see that pattern is the opposite, I'm like, oh, okay, C is not the answer. A and B are good options to kind of consider, right? So those are the tricky options to really think about. Okay. Option choice A, increased mineralocorticoids, fits the picture, right? It makes sense why you have low sodium and high potassium with a low bicarbonate. That fits the aldosterone effect not happening. So you have a reduced aldosterone effect, reduced mineralocorticoids. But what about B? B is 11-DOC, 11-deoxycorticosterone. So I like to think of that as aldosterone's younger brother. It does the same thing as aldosterone, but just in a different way. And in patients with an increased 11-DOC or 11-deoxycorticosterone, you would expect aldosterone effect. So whatever B would present with, option choice B would also present with that. So in the setting of high sodium, low potassium, and high bicarbonate. So this patient, just by looking at the patient, I diagnosed this patient with a 21 hydroxylase deficiency, which then would allow me to get to the answer that I did. So You know, it's a little complicated. It's a lot of little details to focus on. There's a nice chart in first aid, which I think I recommend everybody go look at, that separates the zona glomerulosa, fasciculata, reticularis, and really understand how these little things take effect and how they present. So the big clues in this one: low sodium, high potassium, low bicarb in the setting of virilization is a 21 hydroxylase deficiency, which leads to low mineralocorticoids. So hopefully that helps. If that, you know, that gets more confusing for you guys, if you guys need some more time to look at it, open up your first aid, go to that page, and really try to do some practice questions on that. But great job, guys.
That is definitely good advice. And I was going to actually include that image here, but I neglected to add that. We do have, I'll put the link in the chat once we complete tonight's session, but I'll share a link to tonight's test, which we can share through QMax, and you can dig deeper into all of the questions as well as all of the explanations. Okay, so with that, we have come to the final question of the night, question number 4. I'll do our best to hit this one out of the park. And what we have here, again, we've got some lab results. We've covered up those answer choices. So we need to start by looking at that lead-in. Which of the following is the most likely cause of this patient's current symptoms? Okay, so we're going to be, we know what it is we're looking for. We're going to be looking, it's going to be kind of a two-step question, right? You're going to have to, figure out what's happening with this patient and what is causing them to present in this way. So with that, let us read the vignette. A 32-year-old woman presents to the clinic with complaints of a sore throat, fever, and chills for the past few weeks. She works as an elementary school teacher and has a history of Graves' disease, which is managed with medications. Temperature is 38.3. Physical examination shows no abnormalities. Lab studies show hemoglobin 14.7, white blood cell count 3,500, absolute neutrophil count 1,300, thyroid stimulating hormone 2.4, thyroxine 8.6. So once more, which of the following is the most likely cause of this patient's current symptoms? Think about how you would approach this question as I pass it over to Abraham.
All right, so we got, again, a little different question here. Finally, a question not about the serum labs and really asking the cause of the symptoms. Okay, this is a very typical style of question, and you want to be able to kind of get an idea of what's going on, get the story, use the labs to help you, use the history. So let's go through, let's highlight some keywords here, and let's try to figure out what's going on here. So the keywords in this question, as we see, are most likely to cause and the patient's current symptoms, right? So the lead-in is important there. So you want to know what the underlying cause of the symptoms are. Okay, we have a 32-year-old woman. She came in with sore throat, fever, chills for the past few weeks. Okay, that's pretty long to have these symptoms, but a few weeks. She's an elementary school teacher. Okay, history of Graves' disease and has a fever. When I look at the labs, I see, hemoglobin's all right. White blood cells a little bit down, actually, 3,500's down. Expecting, close to 10,000 mark, between that. NC, which is absolute neutrophil count, is 1,300, which is also low. We typically expect that above kind of the 1,500, close to 2,000 range. TSH is 2.4, which is actually within normal ranges. And my thyroxine, which is 8.6, which is also within normal ranges. Okay, so I'm just letting you guys know, you guys will have the actual lab values on the exam day. So I just want to let you know, I highlighted the ones that are abnormal. The rest of them, you can assume they're normal in the situation. What is the most likely cause of the patient's current symptoms? Okay, this is a little bit trickier question. You have to kind of use the history, use the story, think about what's going on in this patient, what would explain why has these current symptoms, and especially using the highlighted words, they have some, meaning behind it. So take a second, start thinking about your differentials, and let's pop up through the options here. Okay, so we have option choice E, virus-induced neutropenia. Option choice D, thyroid storm. Option choice C, drug-induced neutropenia. Option choice B, autoimmune disease. Option choice A, aplastic anemia. Okay, so you have kind of unique all over the place options, but really one that fits this situation the best. And this is a high yield topic, and this is one that people often skip over when it comes to thyroid and understanding kind of how it works. Now, take a second, go through one more time, notice the abnormal labs, notice the presentation, and why don't you guys go ahead and pick an answer based on what you guys think.
Okay, the poll has been launched. It's really up to you. You've got 5 choices here. Which of them do you think is the most likely cause of this patient's symptoms? Kind of a good question here to close out the night. Endocrine often, lots of labs, plenty to think through. So we're going to have pull a name from the virtual hat here, and we've got a special discount for those in attendance. So, and again, you do have to be here in order to win the raffle. So hang in there, guys. Let's see. Well, 3/4 of you have voted, so I'm just going to give you a few more seconds, and I'm going to shut down the voting. Keep an eye on the clock here. We're getting close to the top of the hour. So we're going to go ahead and close it, share the results. And let's see, about half of you went with drug-induced neutropenia. About a fifth of you went with virus-induced neutropenia. Okay. 14% with the thyroid storm, and about 10% went with autoimmune disease. And a couple of you went with aplastic anemia. Okay, well, with that, we need to figure out, hey, the crowd go 4 for 4 tonight. Let's see. And the answer is, well, it is answer choice C. It's not answer choice D. Answer choice C, drug-induced neutropenia. So great job, everybody. That, you know, that's a tough one, and many of you were able to deliver on it. But if you didn't, that's okay. And even if you did get it right, there's a lot to be gained just from listening to Abraham's explanation. So everybody, tune in here, lock in as we walk through this final one. Abraham.
Jeff, I think the poll is still up on my end.
Oh, okay. Sorry about that.
All right. So great job, guys. You know, this was a kind of a classic question. You want to drop in the question box, what you think the underlying drug or whatever it is that caused this neutropenia. I saw somebody already say it in the options. You can already type it in here, but I'll give it a couple seconds for you guys. But it's important to kind of look at the full picture, right? Everybody will be first to kind of will start blaming the thyroid for everything. But when you look at the labs, the TSH and the thyroxine are both within normal ranges. And really, when you start thinking about someone who's having sore throat, fever, chills for a few weeks, think about recurrent infections. You think about patients who have this fever, and then when you look at the labs, you notice, okay, their counts are low. And why is their neutrophils only 1,300, right? That's low. And you start looking at, neutropenia. All right. So I see a couple of right options here, a couple of incorrect ones. So let's talk about this. So somebody said glucocorticoid. So glucocorticoid is not the answer. Glucocorticoid actually causes increased neutrophil count because of demarginalization, but it does increase risk for infection. So that's a good thought, but that wouldn't be the other. Somebody else said levothyroxine. Levothyroxine is also not the correct answer because you would not give that in a hyperthyroid, right? Graves' disease is a hyperthyroid. You would give it in a hypothyroid case. And levothyroxine does not cause neutropenia. Now, what would be the actual answer then? Well, the treatment methimazole and PTU. I see a lot of people put that in there as well. So that's the correct answer. So methimazole and PTU are my antithyroid medications. So in a hyperthyroid situation, such as Graves' disease, those are my keystone drugs that I use to mainly treat these patients. And it's doing a good job. It's working. Your TSHs and thyroxine are within normal ranges. her Graves' disease is well controlled. But dangerous but very high yield side effect is agranulocytosis. Step 1 loves agranulocytosis. So you have to know all the drugs that cause agranulocytosis like the back of your hand. I'm going to quickly list off the high yield ones that you should know. So carbamazepine, P2U methimazole, and there's an antipsychotic medication called clozapine that can also cause it. So in this situation, this is an agranulocytosis, and we know neutrophils are granulocytes. So we start getting low levels of neutrophils or drug-induced neutropenia. They can call it agranulocytosis. They can call it many different words, but C is the correct answer. Autoimmune, we know Graves is an autoimmune disease, but wouldn't be the main answer for this. Aplastic anemia, well, the hemoglobin is 14.7, right? So there's not really an anemia aspect to this. And in aplastic anemia, you have platelets, WBCs, and hemoglobin all usually go down together. Thyroid storm, again, TSH and thyroxine are within normal ranges, doesn't fit the picture. And then virus-induced neutropenia, good thought, really, but it wouldn't explain kind of the picture that they're trying to paint here. And right, in the sore throat, you can have some low white blood cell counts in viruses, but the whole thing here is pointing towards P2U and methimazole. So again, good job, guys. This is a high yield one. Make sure you guys lock that knowledge in for future.
Yes, definitely. Excellent. Thank you, Abraham. And thanks, everybody, with that final question about drug-induced neutropenia and Graves' disease. We've completed our endocrine adventure for the night. So nice work. We've covered chronic kidney disease complications, diabetic ketoacidosis, congenital adrenal hyperplasia, and antithyroid drug toxicity. Basically a greatest hits album of endocrine pathology that will definitely show up on your exams. So I do have a link to tonight's test, so you can go to the chat to find that. But again, the thing about endocrinology that I think it's fascinating. It's not really about memorizing a bunch of hormone names and what they do. It's really about understanding that your body is constantly having these conversations with itself through these chemical signals. And when those conversations get disrupted, everything goes sideways in predictable ways. And that's key for you as a future doctor, right? So when we talked about that patient with chronic kidney disease tonight, the high phosphate, low calcium, sky high PTH, that's not random. That's your body desperately trying to maintain calcium homeostasis when the kidneys can't do their job properly. So, it's kind of elegant in a everything is broken, but we're still trying sort of way. So anyway, endocrine's always an interesting topic, and I'm glad that so many of you were able to hang in there tonight. We're going to be encountering endocrine disorders in patients across just about every specialty, and the things we covered, it's not just test material. This is a foundation for how you're going to diagnose and treat conditions like diabetes and thyroid disease and adrenal disorders and all the rest. So these are real patients whose lives really depend on your understanding of these principles. So again, my hat's off to you. You guys did a great job tonight.